Dr. Chad Lavender with us right now. If you are a regular listener, you know that through Mike DeCourcy, we were talking about this a few weeks ago, that he wrote a piece on Dr. Lavender's breakthrough procedure of getting athletes back onto the field, court, whatever, a lot faster after an ACL tear than ever before, running, sprinting after just 6 weeks, which is nuts. Back in the day, Doc, I remember the big scar that started about 8 inches above your knee, and it ran about 8 inches below the knee, and everybody's on the big braces for 2 months and all that. It was just like a 6-month ordeal.
Yeah, it's amazing how far technology has came to allow us to do the procedure in a much more minimally invasive fashion, right? So smaller incisions, really a poke hole surgery is what we like to say more than anything. Small incisions of centimeter or so, and all that's because of the advances that we've had from technology, instrumentation, and obviously our cameras are HD or 4K. Now, so you see a lot more with the standard arthroscopy equipment.
And I kind of asked you this a minute ago, but what led you down this rabbit hole? What was like, one day you're doing whatever it is you're doing, and I'm sure it involved an ACL injury, but what was hey, let's look at this.
So specifically, I saw several patients come in who were years out from their ACL, and they had these cysts around the graft in the bones. And so that was dead space, and fluid was in the bone next to the ACL graft on MRI scans. And these patients were years out from their ACL reconstructions. And it made me start to think, is there something that we could put, like a biologic product, into that cavity, okay, to help the healing process? And that's specifically how I got into the tract of looking at biologics, looking at different types of biologics, and actually placing bone graft next to the actual reconstruction that we do.
And, we keep saying the ACL, anterior cruciate ligament, but there's the MCL, and is it the PCL, posterior? Is there a posterior cruciate ligament?
PCL.
So different, but the ACL is the most common, and I guess that's because it's on the outside and it takes the bend more than, or it bends away more frequently.
The non-contact loading injury typically tears the ACL, and many times you'll have an MCL sprain or tear with it, and then also a meniscus tear, such as a lateral meniscus tear. Those are the more common injury patterns. The PCL gets torn in a much higher energy type situation. Yeah.
But obviously this is something that would probably work for all of those, I would assume.
Yeah, I mean,
but
you could translate it, but we focused on just the ACL portion of this. Yeah.
So what now? Is it just time? Is it just getting as many of these done as possible to get to see is this working, or do we have numbers?
Yeah, so we've tested athletes the last several years at around the 12-week mark, and what we found is that at 12 weeks, the fertilized ACL group is 75% functioning on hop testing compared to the non-operative extremity. So what that means is when you take the normal extremity and then the injured ACL extremity, that it's about 75% of the way healed on functional testing at 12 weeks. Normally, you're going to look at 5-7 months for that type of recovery, and so that shows us that they are improving. And to be honest, no one's even tested patients at that early time point before 12 weeks. So just testing that many patients has helped give us knowledge about that there are patients, like Mike said, there are patients that can recover faster, go through the process faster, especially with the newer technologies we have available. So all of that information is important. And I mean, there's someone today calling our 2-year post-ops, actually. So, we continually follow this up, look at our numbers. We have a running program here where we continue to look at our results. As it relates, though, to our bigger studies, our next step is a multi-center trial where we will actually take patients that pass their functional testing at 12 weeks and try to return, see if they can return safely at 4.5 to 5 months out.
Question from Matt. Eventually, he says, "Do you see this surgical procedure being used in other joint injuries, shoulders, rotator cuff tears, things like that?"
So the process that I do is very specific to an ACL reconstruction, but there is no
Because of the hole?
question, yeah, because of the holes. But there's no question that the biologics that I use, other surgeons are out there using them in rotator cuff repairs, and we do some of that here too. But honestly, you're going to see in the next 5 to 10 years just an explosion of all these biologics being used in different injuries, whether it's rotator cuffs or labrum tears, the meniscus tears that we talked about. Just there is a precedent for that, and that's what I taught when Mike had interviewed me. He said, "Well, will everybody be doing your procedure in 5 years?" And I said, "I can't say that everybody will be doing our specific concentration or procedure, but people will be using aspects of the procedure that we have learned in the future in the next 5 to 10 years, we believe." And you see a lot of it in the rotator cuff world, a lot of biologics used. Yes.
Actually, and I've told you, our next guest that is coming up to join in the next segment, dealing with an ACL rehab right now. He's kind of further along with that. It's been a minute, so his is going along. I'm sure he wished he could have gotten that procedure done as well. But how long? Right now, I would imagine the cost is keeping this down to where, or is this for special circumstances, or these only for circumstances that you guys are looking for specifically?
I think a big part of it, big aspect of it is cost. Obviously, it's a little more expensive to the hospital or the system or the insurance than a standard ACL reconstruction. However, the biggest thing is just having research and data over time, right? And we've been doing this for 3 years, 4 years, but honestly, we need 5 to 10 year results to really be able to go out and say we think that this is something that's reasonable and works efficiently, rather than just having small sample sizes. That's why I always talk about sticking to the specifics of research processes, and the next step for us is to do a multi-center where the largest institutions in the country will be doing this procedure. We gather all of our results, and we look at those results. We see if athletes can actually return to play faster, and we really critically analyze all of those results. That's the next step. And really, after that happens, that's when I think you would see it used as a mainstream technique, if that makes sense.
Well, if I ever need it, and I hope that I don't, I'm going to keep you on speed dial, man. But definitely keep us up to date on how it goes. We'll be keeping an eye on it and looking forward to it, though.
Thank you so much for having me on, Jim.